Question number 1. What is total parenteral nutrition (TPN)? Option A. Nutrition delivered through a nasogastric tube. Option B. Nutrition delivered entirely through the gastrointestinal tract. Option C. Nutrition delivered entirely through a central venous line bypassing the GI tract. Option D. Oral supplementation with vitamins and minerals. The correct answer is option C. Nutrition delivered entirely through a central venous line bypassing the GI tract. Rationale. TPN provides all nutritional requirements: carbohydrates, protein, fats, vitamin, minerals, water intravenously bypassing the GI tract completely. It is used when the guts cannot be used. Question number 2. Which venous axis site is most commonly used for TPN administration? Option A. Peripheral vein. Option B. Central vein. Option C. Femoral vein. Option D. External jugular vein only. The correct answer is option B. Central vein. Rationale. TPN must be given via central vein because it is highly osmolality. Would be damage peripheral vein causing thrombophlebitis. Central vein have rapid blood flow that dilute the solution quickly. Question number 3. What is the most common and serious metabolic complication of TPN? Option A. Hyponatremia. Option B. Hypoglycemia. Option C. Metabolic alkalosis. Option D. Hypercalcemia. The correct answer is option B. Hyperglycemia. Rationale. Hyperglycemia is the most common metabolic complication of TPN because of the high dextrose content. Blood glucose must be monitored every 4 to 6 hours. Insulin may be added directly to the TPN bag. Question number 4. Refeeding syndrome in TPN patient is primarily caused by a sudden drop in option A. Sodium. Option B. Phosphate. Option C. Calcium. Option D. Bicarbonate. The correct answer is option B. Phosphate. Rationale. Refeeding syndrome is characterized by severe hypophosphatemia when nutrition is restarted after prolonged starvation. Phosphate shift into cell with glucose metabolism, causing dangerously low serum level. Question number 5. Which macronutrient in TPN provides the most calorie per gram? Option A. Dextrose. Option B. Amino acids. Option C. Lipid emulsions. Option D. Electrolytes. The correct answer is option C. Lipid emulsions. Rationale. Lipid emulsions provide 9 kilocalorie per gram, making the most calorie dense micronutrient. Dextrose provide 3.4 kilocalorie per gram and amino acid provide 4 kilocalorie per gram. Question number 6. What is the primary purpose of adding lipid emulsions to TPN? Option A. To prevent hyperglycemia. Option B. To provide essential fatty acid and calories. Option C. To maintain osmolality. Option D. To replace lost electrolyte. The correct answer option B. To provide essential fatty acid and calories. Rationale. Lipid emulsions in TPN provide essential fatty acid and are concentrated calorie source. Without fat, essential fatty acid deficiency develops within 1 to 3 weeks. Question number 7. Which of the following is a sign of catheter-related bloodstream infection in a TPN patient? Option A. Bradycardia and hypotension. Option B. Fever, chills, and redness or tenderness at the catheter site. Option C. Peripheral edema and weight gain. Option D. Hyperglycemia alone. The correct answer is option B. Fever, chills, redness, tenderness at the catheter site. Rationale. CRBSI present with fever, chills, and local signs of infection at the catheter site. Blood culture should be drawn immediately and antibiotics started. The catheter may need to be removed. Question number 8. How should TPN be discontinued to prevent hypoglycemia? Option A. Stop abruptly when the bag is empty. Option B. Taper the rate gradually over several hours before stopping. Option C. Switch immediately to a 10% dextrose infusion only. Option D. Double the rate for the last hour then stop. The correct answer is option B. Taper the rate gradually over several hours before stopping. Rationale. TPN should be tapered gradually to allow the pancreas to adjust insulin secretion and prevent rebound hypoglycemia. Question number 9. Essential fatty acid deficiency from fat-free TPN cause with classical skin findings. Option A. Jaundice. Option B. Dry, scaly skin and hair loss. Option C. Purpura. Option D. Pitting edema. The correct answer is option B. Dry, scaly skin and hair loss. Rationale. EFAD from prolonged fat-free TPN causes dry, scaly, desquamating skin, hair loss and impaired wound healing. At least 4% of total calories should come from fat to prevent EFAD. Question number 10. Which laboratory value is the best indicator for long-term nutritional adequacy in a TPN patient? Option A. Serum albumin. Option B. Serum prealbumin. Option C. Blood glucose. Option D. Serum sodium. The correct answer is option B. Serum prealbumin. Rationale. Pre-albumin is the best short to medium term indicator of nutritional status and TPN adequacy. Albumin reflects chronic nutritional state. Pre-albumin change more quickly with nutritional interventions. Question number 11. TPN associated liver disease is characterized by option A. Hypoglycemia and hyperkalemia. Option B. Elevated liver enzymes and hepatic steatosis. Option C. Decreased bilirubin and improved liver function. Option D. Jaundice with normal liver enzymes. The correct answer is option B. Elevated liver enzymes and hepatic steatosis. Rationale. PNALD manifests as hepatic steatosis, cholestasis, and elevated liver enzymes. It is a major long-term complication of TPN. Question number 12. Which electrolyte is most commonly added to TPN bag to prevent cardiac arrhythmias? Option A. Calcium. Option B. Potassium. Option C. Magnesium. Option D. Phosphate. The correct answer is option B. Potassium. Rationale. Potassium is routinely added to TPN to maintain normal serum level and prevent hypokalemia, inducing cardiac arrhythmias. Level must be monitored daily. Question number 13. The all-in-one or 3-in-1 TPN formulation contains option A. Dextrose and amino acid only. Option B. Dextrose, amino acids and lipid emulsions combined in one bag. Option C. Lipids and vitamins only. Option D. Amino acids and electrolytes only. The correct answer is option B. Dextrose, amino acids and lipid emulsions combined in one bag. Rationale. 3-in-1 combines dextrose, amino acid and lipid emulsions in a single bag. The advantage is convenience. The disadvantage is that harder to visual Inspect for particulate matters. Question number 14. What is the recommended blood glucose target range for TPN patient in ICU? Option A 60 to 80 mg per dl. Option B 140 to 180 mg per dl. Option C 200 to 250 mg per dl. Option D 300 to 350 mg per dl. The correct answer is option B 140 to 180 mg per dl. Rational. Correct evidence supports a blood glucose target of 140 to 180 mg per dl in critically ill patients receiving TPN. Tight control below 110 mg per dl increases hypoglycemia risk. Question number 15. Which condition is an absolute indication for TPN? Option A mild anorexia with functional GI tract. Option B short bowel syndrome with less than 100 cm of functional small intestine. Option C post-operative nausea lasting 24 hours. Option D mild inflammatory bowel disease. The correct answer is option B short bowel syndrome with less than 100 cm of functional small intestine. Rational. Short bowel syndrome with severely limited functional gut is a classic absolute indication for TPN, as the remaining gut cannot absorb sufficient nutrients. Other indications include bowel obstructions, severe malabsorption, and GA fistula. Question number 16. Normal saline is classified as which type of IV fluid? Option A hypotonic crystalloid. Option B isotonic crystalloid. Option C hypertonic crystalloid. Option D colloid. The correct answer is option B isotonic crystalloid. Rational. 0.9% NS has an osmolality of approximately 308 osmolarity per liter, close to plasma, approximately 285 to 295 osmolarity per liter, making it an isotonic crystalloid. It distributes throughout the extracellular fluid compartment. Question number 17. Which IV fluid is most appropriate for hypovolemic shock resuscitation? Option A 5% dextrose. Option B of normal saline. Option C RL. Option D 50% dextrose. The correct answer is option C RL lactate ringers. Rational. Isotonic crystalloids are the first line fluids for hypovolemic shock. They expand intravascular volume effectively. Dextrose in 5% water and of normal saline are hypotonic and distribute into cell, provide little volume expansion. Question number 18. 5% dextrose in water is considered physiologically. Option A isotonic in the bag but effectively hypotonic once infused. Option B hypertonic in the bag and hypertonic once infused. Option C isotonic in the bag and isotonic once infused. Option D hypertonic in the bag but hypotonic once infused. The correct answer is option A isotonic in the bag but effectively hypotonic once infused. Rational. Dextrose 5% in water is isotonic in bag but once infused, the dextrose is rapidly metabolized, leaving free water, making it effectively hypotonic. It distributes throughout all body water compartments, including intracellular. Question number 19. Large volume of 0.9% NS can cause which acid-base disturbance? Option A metabolic alkalosis. Option B hyperchloremic metabolic acidosis. Option C respiratory acidosis. Option D respiratory alkalosis. The correct answer is option B hyperchloremic metabolic acidosis. Rationale: excess 0.9% of NS cause a dilutional hyperchloremic metabolic acidosis due to chloride-loaded and bicarbonate dilution. Lactate ringers is more balanced. Question number 20. Lactated ringer solution contain all of the following aspect. Option A, sodium. Option B, potassium. Option C, lactate. Option D, bicarbonate. The correct answer is option D, bicarbonate. Rationale: lactated ringers contains sodium, potassium, calcium, chloride and lactate. It does not contain bicarbonate directly. Lactate is converted to bicarbonate by the liver. Question number 21. Which IV fluid is contraindicated in patient with traumatic brain injury due to risk of cerebral edema? Option A, 0.9% normal saline. Option B, lactated ringers. Option C, hypertonic saline. Option D, dextrose in 5% water. The correct answer is option D, dextrose in 5% in water. Rationale: dextrose 5% in water is effectively hypotonic and causes water to shift into brain cells, worsening cerebral brain edema and traumatic brain injury. Isotonic fluid NSRL or hypertonic salines are preferred. Hypertonic salines actually reduce cerebral edema. Question number 22. Hypertonic saline 3% NS is used to clinically to treat option A, hypernatremia, option B, dehydration from vomiting, option C, severe symptomatic hyponatremia and cerebral edema, option D, metabolic alkalosis. The correct answer is option C, severe symptomatic hyponatremia and cerebral edema. Rationale: 3% NS is used in severe symptomatic hyponatremia and to reduce cerebral edema in traumatic brain injury stroke by drawing water out of brain cells. It must be given slowly to prevent osmotic demyelination. Question number 23. What is the primary compartment that IV crystalloids expand? Option A, intracellular fluid. Option B, extracellular fluid. Option C, intravascular compartment only. Option D, intracellular and intravascular equally. The correct answer is option B, extracellular fluid. Rationale: crystalloids distribute throughout the entire cellular fluid compartment. Only about 25% of isotonic crystalloid bolus remain intravascularly after 1 hour. Question number 24. Colloids are preferred over crystalloids in which situation? Option A, routine hydration maintenance. Option B, severe hypoalbuminemia causing oncotic pressure loss and refractory edema. Option C, replacement of mild dehydration. Option D, correction of hypernatremia. The correct answer is option B, severe hypoalbuminemia causing oncotic pressure loss and refractory edema. Rationale: colloids remain in the intravascular space longer due to their large molecules that exert oncotic pressure. They are preferred in the condition of low oncotic pressure where crystalloids rapidly leak into interstitium. Question number 25. Which IV fluid is the best choice for a patient with hyponatremia caused by SIADH? Option A, dextrose 5% in water. Option B, half normal saline. Option C, 3% NS. Option D, lactated ringers. The correct answer is option C, 3% NS. Rationale: In severe symptomatic SIADH related hyponatremia, hypertonic saline is given to rapidly raise sodium and resolve symptoms. Hypotonic fluid would be worsen hyponatremia. Question number 26. What is the maximum safe rate of sodium correction in chronic hypernatremia to prevent osmotic demyelination syndrome? Option A, 1 to 2 mg per liter per hour without limits. Option B, no more than 8 to 10 mg per liter per 24 hours. Option C, 20 mg per liter per hour. Option D, 30 mg per liter per day. The correct answer is option B, no more than 8 to 10 mg per liter per 24 hours. Rational. Sodium correction in chronic hyponatremia should not exceed 8 to 10 mg per liter in 24 hours to prevent osmotic demyelination syndrome, which cause irreversible neurological damage. Question number 27. Which IV fluid is isotonic but should not be given to a patient with hyperkalemia? Option A, 0.9% NS. Option B, dextrose 5% in water. Option C, lactated ringers. Option D, 3% normal saline. The correct answer is option C, lactated ringers. Rational. Lactated ringers contain 4 mg per liter of potassium. In patients with hyperkalemia, this can worsen potassium level. Normal saline is preferred in hyperkalemia. Question number 28. 10% dextrose in water is primarily used for option A, volume resuscitation, option B, treatment of severe hypoglycemia or neonatal nutrition, option C, correction of hypernatremia, option D, bowel preparation. The correct answer is option B, treatment of severe hypoglycemia or neonatal nutrition. Rational. Dextrose 10% in water provides a more concentrated glucose sources and is used to treat severe hypoglycemia in neonate nutrition and when higher caloric density is needed without excess fluid volume. Question number 29. Which statement about half normal saline is true? Option A, it is isotonic and used for volume resuscitation. Option B, it is hypotonic and distribute freely into cells. Option C, it is hypertonic and used for cerebral edema. Option D, it contains potassium. The correct answer is option B, it is hypotonic and distribute freely into cell. Rational. Of normal saline is hypotonic. Once infused, it distributes into both extracellular and intracellular compartment. It is used for free water replacement in hypernatremia, but is not appropriate for volume resuscitation. Question number 30. Albumin 25% solution is considered A. Option A, hypotonic crystalloid. Option B, isotonic crystalloid. Option C, hypertonic colloid. Option D, hypertonic crystalloids. The correct answer is option C, hypertonic colloid. Rational. 25% albumin is a hyperoncotic colloid. It draws interstitial fluid into the intravascular space and it is used in hepatorenal syndrome and SPP treatment and severe hypoalbuminemia. It provides more oncotic pull than 5% albumin. Question number 31. A patient receiving 1 liter of 0.9% NS IV will be retained approximately how much intravascularly after equilibration? Option A, 1 liter ml. Option B, 750 ml. Option C, 250 ml. Option D, 100 ml. The correct answer is option C, 250 ml. Rational. Since isotonic crystalloids distribute throughout the entire extracellular space, approximately 250 ml of 1 liter of normal saline remains intravascular after equilibration. Question number 32. Plasmolite is preferred over normal saline because it option A contain more chloride than plasma, option B is more alkaline and balanced, causing less hyperchloremic acidosis, option C contains glucose, option D contains albumin. The correct answer is option B is more alkaline and balanced, causing less hyperchloremic acidosis. Rational. Plasmolite is balanced crystalloid with electrolyte concentration close to plasma, a pH of 7.4 and acetate gluconate as buffer. It causes less hyperchloremic metabolic acidosis than normal saline. Question number 33. Which IV fluid formulation is most appropriate for maintenance fluid in evaluemic adult? Option A 0.9% NS at 125 ml per hour. Option B dextrose 5% in water with 20 ml per liter KCl at maintenance rate. Option C 3% NS at 50 ml per hour. Option D albumin 5% at maintenance rate. The correct answer is option B dextrose 5% in water with 20 ml per KCl at maintenance rate. Rational. Standard adult maintenance IV fluids are typically hypotonic saline with dextrose. The hypotonic components provide free water, glucose, provide minimal calorie, and potassium replaces losses. Question number 34. Which condition is a contraindication to using lactated ringer solutions? Option A burns, option B metabolic acidosis, option C severe liver disease, option D trauma. The correct answer is option C severe liver disease. Rational. In severe liver disease, the liver cannot convert lactate to bicarbonate. So, RL can worsen lactic acidosis. Normal saline or plasmolite is preferred. RL is also avoided in lactic acidosis for the same reason. Question number 35. Potassium chloride should never be administered as option A dilute infusion in NS or dextrose 5% in water. Option B a slow infusion via peripheral IV. Option C a direct undiluted IV push. Option D on addition to a maintenance fluid bag. The correct answer is option C a direct undiluted IV push. Rational. Undiluted IV push of potassium chloride is never done. It causes fatal cardiac arrest. KCl must always be diluted and given slowly, maximum 10 to 20 ml per hour via peripheral and 20 to 40 ml per hour via central and monitoring. Question number 36. What differentiates TPN from peripheral parenteral nutrition? Option A. TPN is given orally, PPN is given IV. Option B. TPN uses a central vein and can provide full nutrition. PPN causes a peripheral vein and provides partial or supplemental nutrition. Option C. TPN contain no lipids. PPNs contain lipids. Option D. TPN is given intermittently. PPN is given continuously. The correct answer is option B. TPN uses a central vein and can provide full nutrition. PPN uses a peripheral vein and provides partial or supplemental nutrition. Rational. TPN via central vein can provide complete nutrition at any osmolality. PPN via peripheral vein is limited to lower osmolality solution, providing partial supplemental nutrition. reducing risk of thrombophlebitis. Question number 37. Which IV fluid contains calcium and is therefore incompatible with blood transfusion? Option A 0.9% normal saline. Option B 5% dextrose in water. Option C RL. Option D plasmolite. The correct answer is option C RL, lactated ringers. Rationale: lactated ringers contains calcium which can cause clotting in blood transfusion tubings by binding to citrate anticoagulant in blood products. Only 0.9% normal saline should be used as a dilute flush with blood products. Question number 38. A TPN patient develops periorbital edema and weight gain of 3 kg in 2 days. The priority nursing action is: Option A increase TPN rate to provide more protein. Option B assess fluid status, restrict fluids, and notify physician for possible fluid overload. Option C administer IV potassium immediately. Option D discontinue TPN permanently. The correct answer is option B assess fluid status, restrict fluids, and notify physician for possible fluid overload. Rationale: rapid weight gain and edema in the TPN patient signal fluid overload. The nurse should assess vital signs, lung sound, urine output, IO balance, and notify the physician. The TPN rate or compositions may need adjustment. Question number 39. A patient receiving 5% dextrose in water IV for 3 days develop confusion and hyponatremia. The most likely cause is: Option A excess sodium in 5% dextrose in water. Option B excess free water from dextrose 5% in water causing dilutional hyponatremia. Option C refeeding syndrome. Option D hyperglycemia from dextrose. The correct answer is option B excess free water from dextrose 5% in water causing dilutional hyponatremia. Rationale: prolonged dextrose 5% in water infusion delivers free water which dilute serum sodium causing dilutional hyponatremia. Dextrose 5% in water should not be used for long-term maintenance hydration in patient at risk for hyponatremia. Question number 40. Which of the following IV fluid has the highest osmolality? Option A 0.9% normal saline. Option B dextrose 5% in water. Option C 3% normal saline. Option D lactated ringers. The correct answer is option C 3% normal saline. Rationale: 3% normal saline has an osmolality of approximately 1026 osmolality per liter, making it the most hypertonic of common IV fluids. It is used specifically to rapidly raise serum sodium and reduce cerebral edema. Question number 41. During TPN administration, the nurse notes the patient urine is frothy and output has dropped. This may indicate: Option A normal urinary changes with TPN. Option B glucose in the urine from hyperglycemia or developing renal complication. Option C adequate hydrational status. Option D electrolyte balance. The correct answer is option B glucose in urine from hyperglycemia or developing renal complications. Rationale: frothy urine and decreased output may indicate renal complications or protein overload. Glyceria signals hyperglycemia exceeding renal threshold. Both require physician notification. Question number 42. Which vitamin is not routinely added to TPN formulations and requires separate supplementation in certain patients? Option A, vitamin C. Option B, vitamin B12. Option C, vitamin K. Option D, vitamin B1. The correct answer is option C, vitamin K. Rationale. Vitamin K is not routinely included in standard TPN multivitamin preparations because it interferes with warfarin anticoagulant therapy, which may TPN patients receive. It must be supplemented separately based on clinical need and INR monitoring. Question number 43. A patient on long-term TPN is most at risk for which trace element deficiency? Option A, iron excess. Option B, zinc deficiency. Option C, calcium toxicity. Option D, iodine toxicity. The correct answer is option B, zinc deficiency. Rational. Zinc deficiency is a common trace element deficiency in long-term TPN patient. Zinc is critical for wound healing, immune function, and taste. It is lost in GA secretion, must be adequately supplemented in TPN. Question number 44. Which IV fluid should be used to mix and administer most IV medications? Option A, lactate ringers. Option B, 0.9% normal saline or dextrose 5% in water. Option C, 3% normal saline. Option D, 50% dextrose. The correct answer is option B, 0.9% normal saline or 5% dextrose in water. Rational. Most IV medications are mixed in 0.9% NS or 5% dextrose in water. Compatibility must be always be checked. For example, phenolphthalein precipitate in dextrose 5% in water and calcium containing medications are incompatible with phosphate containing solutions. Question number 45. What does a positive nitrogen balance in a TPN patient indicate? Option A. The patient is losing muscle mass. Option B. Protein catabolism exceeds protein synthesis. Option C. Protein synthesis exceeds catabolism. The patient is anabolic. Option D. The patient has renal failure. The correct answer is option C. Protein synthesis exceeds catabolism. The patient is anabolic. Rational. Positive nitrogen balance means nitrogen intake exceed nitrogen output is the indicate anabolism. The patient is building tissue, which is the goal of nutritional support. Question number 46. A nurse is hanging a new TPN bag and notice the solution appears cloudy. The correct option is option A. Hang it anyway as cloudiness is normal. Option B. Warm the bag before hanging. Option C. Do not hang it. Return it to pharmacy and obtain a new bag. Option D. Add saline to clear the cloudiness. The correct answer is option C. Do not hang it. Return it to pharmacy and obtain a new bag. Rational. TPN solution should be clear or milky white if lipids are included in a 3-in-1 mixture. Unexpected cloudiness, particulate matter, or color change indicate contamination or incompatibility. The bag must not be hung. It should be returned to pharmacy. Question number 47. When administering IV potassium via peripheral IV, the nurse should monitor for option A, hypertension, option B, burning, pain at IV site and phlebitis, option C, bradypnea, option D, urinary retention. The correct answer is option B, burning, pain at the IV site and phlebitis. Rational. IV potassium is irritating to peripheral vein and cause burning pain at the infusion site and properties. The maximum peripheral concentration is 40 ml per liter at rate no faster than 10 ml per hour. Higher concentration require a central line. Question number 48. Which IV fluid is the fluid of choice for replacing gastrointestinal losses from nasogastric suctioning or vomiting? Option A. Lactated ringers. Option B. Dextrose 5% in water. Option C. 0.9% normal saline with L. Option D. 3% normal saline. The correct answer is 0.9% normal saline with KCl. Rational. Gastric fluid loss through vomiting or NG suction is rich in hydrochloric acid and potassium. Replacement with 0.9% normal saline plus KCl. Correct the question number 49. Which electrolyte disturbance is most commonly seen with excessive dextrose 5% in water infusion? Option A. Hypernatremia. Option B. Hyperkalemia. Option C. Hyponatremia. Option D. Hypercalcemia. The correct answer is option C. Hyponatremia. Rational. Excessive dextrose 5% in water infusion causes dilutional hyponatremia because the glucose is metabolized leaving only free water which dilute plasma sodium. This is especially dangerous in post-operative patient, elderly and those who with SIADH. Question number 50. Before starting TPN, which baseline assessment is most important? Option A. Obtain baseline temperature. Option B. Obtain baseline weight, serum electrolyte, glucose, renal and liver function test. Option C. Check pupillary response. Option D. Assess skin turgor only. The correct answer is option B. Obtain baseline weight, serum electrolyte, glucose, renal and liver function tests. Rational. Before initiating TPN, comprehensive baseline lab and weight must be obtained to guide TPN formulation and monitor for complications. Question number 51. What is the purpose of adding insulin directly to a TPN bag? Option A. To lower blood pressure. Option B. To control hyperglycemia caused by the high dextrose concentration in TPN. Option C. To prevent infection. Option D. To improve nitrogen balance. The correct answer is option B. To control hyperglycemia caused by the high dextrose concentration in TPN. Rational. Regular insulin is commonly added directly to TPN bag to control the hyperglycemia caused by the concentrated dextrose. The typical starting dose of 0.1 units per gram of dextrose, adjusted based on blood glucose monitoring. Thank you for watching this video. Please subscribe my channel. Please like and share to your friends.